All right, we are ready to go, everybody. Thanks very much for being here tonight. It means a lot. I know you've been very busy, and I hope you're enjoying the AAAI conference. But we are going to try to make this interactive. Should be a great event with lots of good information, and it really depends on you helping us out with some excellent questions and responding, because this is going to be a gamified program, so we're going to keep it moving and keep it fresh throughout. You can't do that without scanning this QR code. So the QR code is on your screen. That way you can view the slides as well as ask questions. I've got a tablet for you at home. You should also see a QR code. That's the tablet, just to prove that I have it. I don't know why I would lie. So please do that. There is, on the placards on your tables, there is also a QR code, and that's the same one. Go ahead and scan that, use your device, and that's how we're going to play. All right. And if you don't have the Wi-Fi, there it is. It's Medscape26, capital M is the password. Got it? Cool. So the program is entitled, Is Flexibility the Missing Link in Symptom Relief, Tailoring Intranasal Antihistamine Recommendations? My name is Chuck Vega. I am a clinical professor of family medicine, so I feel really blessed to be part of your community tonight, in allergy, asthma, and immunology. And I have two experts with me. So first is Dr. Ann Ellis. She's a professor of medicine at Queen's University in Kingston, Ontario, Canada. And Dr. Saad Mustafa, who's division head for allergy, immunology, and rheumatology at Rochester Regional Health, a clinical associate professor of medicine at the University of Rochester School of Medicine in beautiful Rochester, New York, where he's from. The local guy made good. So now you should see popping up on your screen your first question. Now this is very important. You're being graded on it. But this is a Family Feud format. How many of you have heard of, don't run it yet, how many of you heard of the Family Feud format? Okay, right? Okay, so there's been a couple iterations of the show. I'm not as familiar with the Steve Harvey version. I am familiar, Richard Dawson would be on TV like at 7:30 on like Wednesdays. I would see it or something when I was growing up. So what we have here are a series of choices. Now, there have been some polls done of your colleagues, and they look at which are the most popular choices from your colleagues, and then you get to vote now. Can you match the most popular choices with a cohort of your colleagues? And this is just a practice question, actually, so you won't be graded. None of this is graded. None of this is recorded. You won't be. It's not like that. But it does make it fun. So name something you might order at a Philadelphia restaurant. Is it a hoagie? Is it a soft pretzel? Is it a roast pork sandwich, a cheesesteak, a water rice, or scrapple? Please mark your answers. Do you two know what water rice is?
I was going to say, what the hell is scrapple?
Scrapple is pork ends that are rolled in cornmeal and baked with deep fat.
I'll put my vote in now that I would say no. That's the next thing I would order.
Okay, so it looks like cheesesteak is the most popular pretzel. Hoagie, you should give some more love for the hoagie, because we were just talking about, I'm from California, and we just don't do sandwiches like they do out here. You have better sandwiches, period, than we have. And water ice, just to close the loop, is where you take, it's not exactly a slushy, it's not like a sorbet, it's water ice. It's sweet, slushy, fun water. Anyway, it sounds like the ultimate thing you might order if you're really drunk, like water, ice. So that's just me, though, in my background. But anyway, let's go to what does our survey say? Yes, cheesesteak is the most popular again. Well, so we nailed it. Hoagie got a little bit more love, and that's how it's going to work. We're not going to belabor this too much. Let's get some content. So we are going to be talking about barriers to intranasal antihistamine use first. Then we'll be talking about how to actually incorporate these into our practice. Should they be incorporated into our practice? How to do so. I'm on the primary care side. I can struggle with getting patients to take appropriate therapy, even for more severe allergic rhinitis. And then for the folks in the specialty community, I think you see cases that are recalcitrant to multiple treatments, but maybe it's because patients aren't always using them right or have different viewpoints. So we're going to bring all of that, or it's more expensive and they don't want to pay for it, which I totally get. We'll be talking about all that and then putting it together at the end for what we call counseling showdown. How do we actually move the needle in getting patients the right treatment and individualizing care so we get the best results. So I'm not going to lecture you all who are experts in the subject about the pathophys of allergic rhinitis. And generally we think about seasonal, we think about perennial. When in Southern California, there's always something going on, and I really look at how persistent are my patient's symptoms and how impactful are my patient's symptoms. But this is incredibly common. So allergic rhinitis is the 5th most common chronic illness in the United States. We're talking anywhere about 15% to 30% of adults. For kids, it's up to 40%. And in a national study looking at medical records, it was found in 13 and 14% of adults and children's charts. Why is there a discrepancy? More patients seem to report symptoms versus having it on charts. It reminds me of a lot of other conditions, obesity being one where we may be recognizing it, but we don't always chart it because we're not trying to do something about it. Now, we're doing a different job with obesity. We need to do the same job when it comes to significant rhinitis symptoms. And the reason is because in my experience, people, and having had allergic rhinitis for I don't know, gosh, a long time now, myself at a mild level, I know it can be very impactful. It can impact your social life. It can impact your work life. It can impact school and other types of function. And it very much has an impact on sleep. About 35 to 50% of folks who are experiencing rhinitis report some form of disability related to their symptoms. And I think sleep is really key. We know how important it is for our function every day. But yeah, if we talk about reduced productivity at work, or if we talk about doing worse in school, or kind of failing in our relationships a little bit, I think sleep is really integral there. Plus, you might be getting more problems with blood pressure and some other sequelae of sleep. But what's your take? I mean, you're seeing the more severe cases, so I'll open up to either of you kind of what you see as the impact in your practice.
I mean, one of the things that surprised me when I got into full-time clinical practice was the school impact, for sure.
Yeah.
I'm an adult-trained like I do internal medicine mainly, but I also see children. And I didn't appreciate the fact that how many kids actually do take days off school because of their AR symptoms. I've always been aware of presenteeism as an issue with adults. They show up for work and don't do as well, or you can see them. Like, I remember in my residency, somebody coming up to me is like, "Ann, I think I have grass allergy," and his eyes were blown up, his nose is blown up, and yet he's here,
right,
doing his daily thing. Is he doing it right? Probably not. So yeah, we see this a lot in our practices.
Yeah, it's interesting that I always think it's in primary care, it's our job to really, let's promote adherence, let's promote the right use of medications, but partly because patients might minimize symptoms, and partly because they're using a combination of things. Sometimes I don't even know what they have at home. They have 3 different antihistamines at home and 2 different nasal preparations, and yet they're using them in an irregular way, which doesn't necessarily follow what I would recommend. Maybe that's part of the problem. But yeah, sometimes I don't want to send somebody who doesn't have the most severe pathology to you. But yeah, I'm sure it works out that way.
I think it's a great comment you made on sleep, because we're engineered to breathe through our nose, and individuals with nasal congestion can kind of compensate by being mouth breathers during the day, but during the night they kind of revert to breathing through their nose again, and that's where you get disrupted sleep. So you see hugely disruptive sleep patterns in people with nasal congestion, and then vice versa. It can affect treatment of other conditions like obstructive sleep apnea, right, individuals using their CPAP. So I think that's actually a really, really important point.
Yeah, I think sleep is really key with this one. But it also has an economic cost. And so, Ann, you want to walk us through that?
Yeah, so I really like this study because it's the first one I've come across that has done a really great, I think it's, instead of an attempt, it's actually done a really good job of giving people this device they can take home and record their symptoms, record their medications, record their days missed from work. And it actually quantified for the first time in a better real world way, rather than these sort of gestaltometer estimates of the cost of allergic rhinitis and again, it's a US based, it's a European study, but extrapolated to US. But here we've got documented findings from real-world patients that 60% of people have reported an impact on their productivity. And they've notably actually documented this presenteeism that we talk about anecdotally all the time. And then when they pulled out the data from the US specifically, those poorly controlled weeks were associated with a cost of about $500 per person due to reduced productivity. So I think this is a more impactful study than this just altimeter of, well, in all of the US, it costs approximately this many $1 million annually, which doesn't mean much on a person-by-person basis.
Right.
And I thought this study really brought that home for
whenever
in front of you.
No, it's a really good point. Whenever I see studies, it's like it's $2.5 billion or it's $4 trillion. It's like, I don't know, like it's really hard for me to put that and wrap my head around that. I know one number is bigger than the other, a lot bigger, but it just, they could say anything and I'd probably frankly believe it. But this is something that I think we all believe in, is just trying to go through some of the basics of disease management.
Yeah, and we always recommend allergen avoidance where possible, which often is impossible, quite frankly. So for those with seasonal triggers, you have to go outdoors at some point. For those who are allergic to cat or dog, everyone's reluctant to get rid of or rehouse Fido or Fluffy. And dust mites, we can do things to minimize exposure, but we can never remove it. So we always then advance to symptom relieving pharmacotherapy. And, you know, in our Canadian world, we're trying harder to push people a little bit faster to the immunotherapy end of the spectrum. But this has been a traditional trajectory of where you go to manage these patients.
I think there's a couple of fun points on that last slide. Just to be aware of the evidence on allergen avoidance, and Anne touched upon it, that can be sometimes impossible. The quality of data for allergen avoidance measures is actually pretty poor. It's a lot of grade D kind of recommendation data. So just to be thoughtful about that when you're asking your patients to do some of these things, which are a pretty heavy lift, or can be on their end, if you're trying to practice patient-centered care. And just for a comment on immunotherapy, I just think everyone should be aware that there's different forms of immunotherapy, right? There's traditional subcutaneous immunotherapy, there's sublingual immunotherapy, there's FDA-approved forms in the United States. There's actually more and more emerging data on intralymphatic immunotherapy, and it's actually starting to be practiced in some spots in the US as well. So just to be aware of different forms, different pros, cons, considerations.
Yeah, and I would never stop at just allergen avoidance strategies. Okay. I would always do that in conjunction with at least pharmacotherapy and or immunotherapy. And it just depends on what level your patients are at when they arrive in your practice and what they're willing to think about. I've always said, as an allergist, with all the extra years of training I've done, it's my moral imperative to at least make sure people are aware of immunotherapy as an option anyway. So.
What's your take on HEPA filters as one means of reducing allergens? Because we have, somebody's got to take. So because I know the evidence is not good, but is it just because maybe the studies haven't been done properly, or is it really more that they may not work?
I mean, there's HEPA filters, and then there's the ones that have gone through the extra certification that are quote unquote certified allergy friendly. There's definitely some data that if you have a really good high quality HEPA filter, you are reducing the allergen burden. But you probably agree, it's usually often not enough. It's helpful, but it's
in terms of improving symptoms, right? Yeah. So I mean, we're all cost conscious. We're going to go through that, I think, later. That cost is one of the big drivers. It's one of the things that, again, being a generalist, no matter what intervention we're talking about, whether it's a HEPA filter, an intranasal treatment, or a vaccine, the more patients have to spend on it, the less it's going to be applied. So that's just universal. And we have other options, which we didn't even mention. So, well, I guess this is just expanding the overall roles of different types of pharmacotherapy for allergic rhinitis. Any comments on these?
Yeah, so I think most patients who wind up in your practice have already tried at least one oral antihistamine. I hope and pray that you've all counseled them on making sure they're choosing second-generation non-sedating antihistamines. We have a Canadian position statement on the risks, benefits, and why you should never be recommending first-generation antihistamines anymore for the treatment of allergic rhinitis, or, in my opinion, for anything. So second-generation antihistamines, again, intranasal antihistamines, we're going to be doing a lot on for the rest of the night, so I won't dwell on that tonight. Nasal steroids, you're lucky enough to have a myriad of these options available to you over the counter in the US. But there's other options like intranasal anticholinergic agents, and I know you added this comment. Do you want to weigh in on why you want to talk about intranasal anticholinergics?
Yeah, I mean, I think it's an underutilized option for people with clear rhinorrhea. There's a lot of individuals who say, I just have a clear runny nose. It's not going to address congestion, sneezing, pruritus. But for clear rhinorrhea, intranasal anticholinergic agents are very, very well tolerated and highly efficacious. So I think it's something that doesn't always come top of mind with the other medications, but it's a nice option to add on. It can be used as needed as well, which is always nice for patients.
Yeah, and I mean, my take on leukotriene receptor antagonists is that generally, I think they are very well tolerated. When we look at the guidelines from 2020, they came out pretty strongly with a concern regarding neuropsychiatric effects, which can be terrible, but are quite rare. Mostly, I just don't think they're very effective is the main thing. And so therefore, when you take a look, as we always do in practice, about risk and benefits, yeah, it's not quite as strong. So that's why we're going to go over recommendations and the guidelines here in 1 second. But yeah, they're further down the list, maybe for certain patients, but I'm just not sure if they would really.
Yeah, those who have comorbid exercise-induced asthma as a subset where they're beneficial, patients who are never going to be compliant to an intranasal anything. Generally speaking, it's 25% of the population on the average that responds to leukotriene receptor antagonists. And one thing I will say is we've done studies, they work within an hour and a half if they're going to work. So I never give more than a week or two. If it hasn't done anything at that point, you can just stop.
Speaking of not more than a week or two, decongestants. I mean, there could be some role, particularly if you have a patient who's very congested at the outset and you want to get them under control as you're initiating an intranasal treatment, if you want to make that treatment more effective. I think that makes sense. I think that, oral or nasal, I might prefer nasal just because, especially with concomitant use of intranasal steroids, I'm not so much worried about a rebound effect because they're on the steroids, and it can work just to get them started while we're waiting for that steroid to kick in. Any comment?
My limit is 3 days.
All right.
Not better than 3 days. I
throw
it out.
That's usually, but I mean, I think patients usually do get at least somewhat better on it. So yes, I think, but there is a role, but yeah, they're not for long-term use, absolutely not. But that's enough about what we think. What do the guidelines actually say?
Yeah, so there are guidelines. I always tell trainees that guidelines are guardrails. They're not always gospel, so be thoughtful about the quality of evidence that's behind them to generate guidelines. But these are Joint Task Force guidelines, practice parameters for intermittent allergic rhinitis. That's different than persistent, which will be on the next slide, for ages 12 and up. And actually, if you look for first-line therapy for intermittent symptoms, it's going to be oral second-generation antihistamines or intranasal antihistamines. And the reason here is because these can be used as needed and you have intermittent symptoms. Even second line is as needed medications with quick onset, like oral second generation antihistamines, pseudoephedrine. Here for severe symptoms or moderate symptoms, you can consider intranasal steroids. But we know the significant difference between intranasal steroids and intranasal antihistamines is steroids have to be used on a daily basis to get full efficacy, whereas intranasal antihistamines can be used PRN. Then third line here is steroids or combination of both. So kind of being thoughtful about the frequency of symptoms, how often they're happening, and maybe delineating between milder and severe symptoms versus the next slide, which is going to talk about persistent allergic rhinitis.
So I think we do our patients a disservice actually by I can give them an intranasal corticosteroid, tell them they should be feeling better. It is an effective treatment, but if you don't mention, it's going to take hours before you feel any effect whatsoever, and days before you start to have a significant effect with a peak effect maybe at 2 weeks. I think that's really important, and that's why they're so far down the list, because here it's all about getting something that's quick. And you are doing away, you maybe didn't mean to, but you're subtly doing some damage to this patient's journey with the illness, because now they're disappointed, like, hey, this thing didn't even work. I tried it for 2 days and nothing was really happening. So, I'm going to go somewhere else, or I'm going to go back to using oxymetolazine for like another 3 weeks because that seemed to work, and then you have a whole new problem on your hands when you see them a month later. So I think that's why we're all here today, is to create this learning community and really counsel patients appropriately. Hit these key points because they make a difference.
Then switching over to the same practice parameters for persistent, now you have persistent symptoms, so using a medication on a daily basis makes a lot of sense, and intranasal steroids are probably have a little more efficacy than intranasal antihistamine, so you see the flip-flop in first and second line. Or for moderate to severe symptoms, you can use combination intranasal steroids and intranasal antihistamines. They actually have very interesting pharmacology where they're synergistic. It's kind of 1 + 1 = 3. And then we kind of flip these with second generation antihistamines and the other options, second and third line. So again, just being thoughtful about how frequently is your patient experiencing these symptoms and what's the best approach tailored for their symptomatology.
So in your practice, sometimes like for asthma, we might have a certain rule in our heads, like if you have so many symptoms per week, so many night symptoms, we're going to go ahead and treat you more persistent. Is there something here, or is it really a quite individualized patient looking at not only symptomatology, but maybe how it affects their function that pushes you, okay, we're going to move more into the persistent category at this point? Yeah. I know there's some criteria, but do those criteria actually followed? Are they followed in clinical practice, or is it really more just get to know your patients and how severe their symptoms might be?
I would say it's a combination of getting the history from your patient, but also looking at their sensitizations. And are you allergic to dust mite? Do you live with a cat or a dog and you're sensitized to those? You're pretty much defining yourself as persistent already or perennial. The other comment I can't help but make as a Canadian is just to highlight a little bit of a difference of where the Canadian practice parameters have deviated from the Joint Task Force is we have intranasal steroids and combination as equally equivalent for first-line agents to go for, regardless of mild to moderate. It's just these are all the pharmacotherapy options. They've all been shown to be effective, and just to recognize that that's an option regardless. So.
Yeah, and I think one of the points is that, by using combination therapy, you're not necessarily gaining a lot. That's, I think, one thing I get concerned with, say with hypertension, is that now we're adding a diuretic and an ACE inhibitor together. Gosh, now you might get a cough, and you might have some leaking of urine or something like that. But here we're not. These drugs are very well tolerated, especially when used correctly, which is how we're going to close this talk. But what you do get is this concentrated drug in a specific area, so you're really going right to the heart. There is some systemic absorption, but generally it's not enough to cause symptoms. It's not enough, especially with steroids. You're not going to get any kind of adrenal issues associated with the use of these agents. And with the antihistamines in particular, you get this very quick onset of action, which we will cover. We'll talk about that. And I think that is so important for patients. Because I think the more patients think of this as a nuisance, they have, and not something that could affect their lives more broadly, they're less patient with it. They want quick relief, and they want it now, because this is just a bother, and I don't want to have to use something every day to whittle this down and make it manageable. I just want something that works right now, and the intranasal antihistamines have that going for them, or the combination, particularly when they have more severe symptoms. And then reduce systemic exposure. Is there a patient in your clinics where you don't get allergy testing, or is pretty much everybody getting allergy testing by the time they reach?
Everybody's getting allergy testing.
Yeah, everybody.
The vast majority do, and I think it's more than just, do you consider immunotherapy or not? I think Anne made a great point. Their sensitizations actually can lead to a little bit more proactive rather than reactive medical treatment. Mm-hmm. If you know they're sensitized to dust mites, moles, pets, that gives you an opportunity to be proactive rather than reactive. Or what season. You want to always start therapeutics before the season comes on. So I think there's a lot of information to be gleaned in the setting of upper and lower airway. There's a lot of information you can learn about asthma with someone's allergy testing. So these are really valuable tools in our office that I think the vast majority of individuals with rhinitis do get skin testing for aeroallergens, certainly not other allergens like foods.
So I guess one question I have is, I could see how that makes sense. And if you have more allergens, more common allergens, especially that they're in your community, it's something you see all the time, and you have a list of 6 in one patient and 3 in the other patient, the exact same patient in terms of their symptoms and their degree of disability related to rhinitis, you're probably more likely to aggressively treat the patient with the 6 allergens, correct? I would be. It makes sense. It's, because, how are they going to do avoidance, right?
Well, the allergist will always go back to the history, right? So just keeping a positive skin test doesn't mean, that means you're sensitized. It doesn't mean you're clinically allergic. So allergists who are doing our jobs properly pride ourselves on matching the symptoms and the history to the affirmatory skin tests as opposed to doing a panel skin test.
Yeah, I just think that when you have dual therapy available to you, if dual therapy is indeed available to you, yeah, it seems like, and you're not really paying much of a cost in terms of side effects. Depends on the cost of the medication, but then yeah, it might be more attractive. So this is just a list, so it's just designed to take us through what the names are. In my view, the generalist view is that intranasal corticosteroids are generally safe, they're well tolerated. They're way more similar than they are different. There's two fluticasone. The one that's used most commonly is the propionate, which might be a little bit less effective than the furoate, but the fluororate's more expensive, so the propionate is actually readily available. So that's one thing I might notice with my patients. I've read a systematic review and meta-analysis, and yeah, there are some differences in terms of allergic rhinitis, non-allergic rhinitis, but yeah, it does seem more similar than different at the end of the day. But what's your take on intranasal corticosteroids before we move on to kind of our next session, focusing on antihistamines?
I think you're right. They're more similar than different. There are nuances, for sure. You'll experience that in your practice. Cyclosinide as a prodrug tends to have less epistaxis, but it also tends to have less efficacy in my hands. Mometasone and for furoate, fluticasone furoate tend to be the most effective as monotherapy. And I have both combination products available to me in Canada. They're both great. Full disclosure, I don't get to use intranasal antihistamines in my own practice. That's why I'm going to turn to Dr. Mustafa about that.
Yeah, any of your thoughts?
These are all approved for allergic rhinitis. A lot of these individuals, you want to think about chronic sinusitis or nasal polyposis, so be thoughtful about that. And a couple of these stuff, intranasal steroids are also approved for sinusitis, so that's just a consideration. But I agree, they have very similar profiles.
Okay. Let's moving on now. So let's now talk about intranasal antihistamines, and we want your opinions now, because we've gathered the community's opinions. Now we'll compare. Remember, we're playing a game here. So name the top reason, so devices out, let's play the feud. Name top reason patients underuse INAH sprays for allergic rhinitis. Is it confusion about symptoms being related to an infection, patient's lack of familiarity, perceived lack of efficacy, underestimation of the severity of allergy, or unpleasant taste or sensation? All seem pretty valid. Let's give you a few seconds to mark your answers. And we're going to take a look at your scores as well in a minute. Maybe that's the next section.
If you haven't picked a team, I'm Nasal Ninjas, by the way.
All right, so looks like we've got some variability here with regards to, and that makes sense. It probably is more than one answer, right? But this was the top one you wanted to select. So it looks like lack of familiarity and unpleasant taste or sensation. Yeah, any reaction to these answers?
I kind of like what you said. I mean, these are all appropriate considerations. There's a lot of confusion of, do I have allergic rhinitis or an upper respiratory infection? What medications, what should I use when? I mean, there's a lot of choices now over the counter in the US at least. So yeah, I mean, I think patients struggle a little bit with all of these.
I'm kind of surprised that perceived lack of efficacy outranks underestimation of the severity of allergy, because I seem to have a lot of time, convincing my patients, no, this seems pretty severe. You should take something every day for it.
I mean, it depends on who's answering the survey. Certainly lack of familiarity doesn't surprise me. Looking at a US audience, I walk into CVS here and everything's over the counter, like every antihistamine, every nasal steroid, all the intranasal antihistamines. I can appreciate why day-to-day person in the US would struggle with this. I would have picked unpleasant taste or sensation, because I've experienced that with patients who have used these products in a combination.
Oh, we will get there. That's great. Okay, and do we have the survey results from the previous survey? Here we go. So lack of familiarity, again, it can be a little overwhelming. There's your taste or sensation now, so we're way up there, and that's it. All right, good. All right, so what are some of the reasons for undertreatment? In my opinion, again, patients underestimate their symptoms and the impact of those symptoms. So that's one of the biggest things that I see. So now I don't usually refer onto allergy, because I find that they're using an antihistamine for daily symptoms. They're using an oral antihistamine once a week. And it's like we have so much room to step up to a more effective therapy intranasally, and then it's just a question of choosing which one it is. And then, but more so, it's the real battle in those cases is getting them to use it routinely, especially at the beginning, so they can get a sense of the efficacy over a course of weeks. And then I don't think they're going to let it go after that. What's your take in terms of some of the undertreatment?
What I see primarily is not realizing it's important enough to go see your doctor about. A lot of patients just, I've lived with this my whole life. This is just my lot in life. They learn to live with their symptoms and they never think to seek medical attention.
Fatalistic.
Yeah. So I think that's where we can really reach out and, find an allergist and find relief, in the words of somebody else. So I think that's the biggest thing that we have to face.
Well, I guess one thing is like, how do you see it? This kind of brings in the how do you refer and when should we be referring? Because I do want to send you the patients who have that severe pathology, who have multiple atopic diseases, and maybe I'm worried that they have polyposis too. So you can work to the best of your abilities. I suppose somebody who just really needs to be convinced, but is that something you'd, kind of like when you get that patient, are you rolling your eyes a little bit, given your background and training? Like, yeah, gosh, if this person just used their intranasal treatment more frequently, we'd probably have already, they wouldn't need to be here.
I think that's a great point.
There's not that many allergists out there. I mean,
that's right.
It's a few and far between.
We have to be thoughtful about the environment we're working at, which has limited resources, long wait times. So
yeah.
I think patients that are particularly ripe for referral to an allergist, you mentioned multiple comorbidities, asthma, food allergies, nasal polyps. Those are people that should absolutely be referred. If they've used appropriate medications and they're still symptomatic and you're starting to think about immunotherapy, I think that's a patient that should absolutely be referred. And then there's individuals who do want to know their sensitizations. So for skin testing. So
that's true.
Yeah, again, we talked a lot about shared decision making, things like that, but you have to be thoughtful about the environment, referring someone to an allergist in Canada where there's less potentially.
We have even less, but yet we're pretty devoted.
Yeah.
Like, particularly in the pediatric population, the concept of introducing good therapies early, including immunotherapy for prevention of future sensitization. I always say there's no bad referral to an allergist, at least to me. I think if
you're too nice.
I think at the end of the day, we can do things that not everybody can do. And I think we can help our patients who suffer with this silent disease. I'm biased. But
No, I'll stick to my guns. But I would say that's great. No, I really appreciate that because there are patients who will just, like I've had nasal congestion for a couple of days. I want to see an allergist. And I'll be like, well, tell me more about your symptoms. I just want to see an allergist. And so that's a little bit different. That is a different, and then I write it and I'm kind of like, oh, I'm sorry. But I make sure patient really wants to see it. Like that's if you read the referral and read between the lines a little bit, you'll see that I did not want to, this was against my will. Because usually
I'll triage that accordingly.
Yes,
but if you say, I've talked to the patient, they really want to know more about immunotherapy, I will triage that accordingly as well.
Yeah, so I try to tee it up. But part of teeing it up is like, usually it's like we tried, they were adherent to, intranasal antihistamines for 4 weeks. Then we added a corticosteroid and still wasn't really doing it. Like that's I think going to be a lot more meat on the bone for y'all. And then and it also advances the care because patients don't want to go backwards. They don't, because unfortunately I have had patients who go to that referral and because of miscommunication they weren't reading what I said, or most likely it just wasn't transmitted appropriately. They wind up back on that same intranasal corticosteroid or intranasal antihistamine solo therapy, and guess what? No funciona bien, didn't work. So I think that so we talked about the barriers with a question. I would again bring up costs as a vital issue here, and so there's various levels. Given everything OTC, that means that your health plan may have a very different perspective on covering from one plan to another in terms of covering some of these very important treatments, which are important, as I said, for not only symptoms, but quality of life. So I think that is one of the big things. And another huge one is just like asthma, you have to teach how to use the device when you're talking about intranasal preparation. So we'll get there. So those are two big things for me. Anything else stand out that maybe we didn't talk about in terms of barriers before we move on?
I think that covers it. Yeah, it's good.
Okay.
Yeah.
Okay, so now we'll go to addressing patient needs and another question for you. So let's take a look at this from a different way. Name a factor that makes symptom control difficult in real-world allergic rhinitis. Is it poor treatment adherence, environmental factors, patient self-management with oral antihistamines, inadequate allergen avoidance, suboptimal medication choice or dose, or patient misconceptions, lack of education? Please mark your answers now. And this is a good time to remind you to go ahead and I have some good questions in the chat, so I will try to put those out there as we move forward. Thanks. And this time we are going to get an update as to who's in the lead. So let's see. It's poor treatment adherence. Yeah, actually, I think that is my number one as well. And a lot of that is born of misconceptions and lack of education. And suboptimal medication choice or dose. Again, that might be, the patients are choosing this. So really, it starts off with just getting a lot of buy-in as to how frequently we want to use. If it's intermittent, maybe you don't have to worry about adherence on a daily or every other day basis. But certainly for more persistent symptoms, we want them to use it more frequently. Okay, great. And what did the surveys say? Okay, more issues with self-management with oral antihistamines.
Yeah, because I would have thought that patient misconceptions fed into the poor treatment adherence.
Yeah.
Because they're almost like a self-fulfilling prophecy.
Yes, there's definitely all of these, like several of them anywhere, are fairly interrelated. Okay, now phlegm fighters, nasal ninjas. I think we're going to see how we're doing so far. So give us a second to tabulate your scores so far. We'll see who's in the lead. And Anne, you were going to front $100 to the winner, is that right?
No,
oh.
Absolutely not.
Loonies? 100 loonies?
You don't want 50 cents, Steve.
Oh, okay. All right. So, okay. So there we go. Okay. So 60. So it looks like we're still within. We got another question coming up. So nasal ninjas, you gotta step it up. You gotta nail this next one. You're close. It's right there. All right. So let's go on to challenges of controlling symptoms.
Yeah, I think we were all going to sort of talk about this, but there's lots of things that everybody is aware of in this practice that, when symptoms come and go, people are not quite sure. They really don't. I have a lot of patients like, I just don't want to take a medication every single day. Are you sure that's what I need? And that's one of the challenges, certainly with monotherapy with nasal steroids. And when patients clearly prefer getting immediate relief, that's where the intranasal antihistamines do have that advantage. But at the end of the day, it's just all comes back to, like I say, that education to reinforce adherence is the real key. And recognizing these are the things that are likely going to trigger your symptoms, but at the end of if you're using your stuff regularly, then you'll have less problems.
You're both probably familiar with this, but I came across recently a study, a randomized trial that compared using daily intranasal corticosteroids with spacing that treatment out over time with similar scores, similar efficacy in terms of total nasal symptoms. So that's an option. I tell my patients who really, whatever product, they have persistent symptoms, they don't want to use it every day. With corticosteroids, if it's every 3 days, it's probably still going to be somewhat helpful. And so and then I talk to them about it. I always have follow-up. The only superpower we have in primary care is continuity. So you can check them again in 2 months and see if it worked or not. So in terms of selecting, so what do you think about in terms of key criteria for selecting treatments?
You're always going to look left. Is that your next?
No, I'm not looking left. I'm looking kind of.
But yeah, no. So I'll say
left.
some things and then I'll turn things over to my learned colleague next to me. I mean, honestly, I make sure that everybody's aware of all of the options that are available to them. I think if they've had symptoms that are significant enough to wind up in my office, they deserve options that fit all of the criteria. That's where our Canadian guidelines put everything on an equal footing, right? Intranasal antihistamines, intranasal steroids, oral antihistamines, and then you value in patient preferences. If people don't want to put something in their nose, then it's fine to keep going with second generation oral antihistamines. But I do reinforce that something that gets treated topically is going to be more effective. But the patient preferences often end up guiding the final route for them anyway.
Yeah, and like I said earlier, I think that costs can blow up all that plan. So it's nice to because we have such limited time in our clinical visits, that it's nice if you know more or less what's available and what's covered on the patient's insurance plan, because you can have this great eloquent discussion, get all this buy-in, and it's very deflating when they go to the pharmacy and like, that's $45 and I can't afford that. That's a big problem.
And I think we all know this, but it's important to be cognizant that many individuals can require more than one of these therapies at the same time, right? And you can mix and match. They have the excellent safety profile, so many are synergistic. Multiple can end up on multiple medications. Of course, cost is a consideration, but you have the privilege of trying to find the right regimen that works for the patient in front of you.
So Shahzad, do you want to go through some of the pharmacokinetics?
So we're going to talk about a couple of the intranasal antihistamines, azalastin, 0.1%, and the next slide will be 0.15%. This is indicated in individuals 12 years in age and older for allergic rhinitis and vasomotor rhinitis, so individuals with chronic rhinitis who have maybe negative skin testing for aeroallergens. The beauty of nasal antihistamines is that they have a very quick onset of action within minutes, 15 minutes, and they have pretty good duration, 12 hours. Incredibly high efficacy for nasal symptoms, The adverse effects, so importantly, epistaxis is very, very rare with nasal antihistamines. Epistaxis is much more of a problem with nasal steroids, but much less common with nasal antihistamines. But you do get a kind of a bad taste if it drips down your throat, and individuals do complain about that. The rest of the side effects there are really clinically not that meaningful. And then the next slide is the same nasal antihistamine at a different concentration, works slightly slower but longer duration of action with significant improvement in nasal congestion scores and similar adverse effects. But again, nasal antihistamines are very, very well tolerated.
So I was reading about the bitter taste associated with azalastin, and I know that like in its initial studies, it was fairly high, like 19%. But then in subsequent studies after reformulation, it dropped to 8%.
Yeah.
And so, there have been changes. It's not as severe as it was, after they reformulated. And I think it's like added sucralose to mitigate against some of that taste, but it's still something we have to guard against, and that's how we're going to close this actually, which is practical application, how to teach how to use these agents.
And then there's one more nasal antihistamine, olopatadine, 0.6%. Again, approved over 12 years of age and older. Pretty quick onset of action within 30 minutes with 12 hours duration. Again, improves nasal congestion scores. Here, a similar side effect profile again, and I want to reiterate beyond the taste, the others are really clinically we don't come across too often. So again, as needed medications that are highly efficacious for nasal symptoms in the setting of allergic and in some cases non-allergic rhinitis.
So a question came in, is there a difference in potency between azalastin and olopatadine? Or are they more similar than different? Kind of like
I would argue, like we talked about nasal steroids before, there's more similarities than differences. It's really access what's available in your area.
Yeah.
And I certainly can speak to the original formulation of azalastin. We've actually studied that in our environmental exposure unit, and we are one of the studies that showed the 15-minute onset of action as being accurate. So.
And if you want to reach for something with more potency that's evidence-based, then you're going to add the intranasal corticosteroid to one of these agents, and you have two products that can do so. So that's kind of exciting. I mean, and is there, I'm sure off-label, there's a ton of folks who just use two different inhalers, correct? And is that still legitimate? Then one with an intranasal antihistamine and one with an intranasal corticosteroid? It's still going to, at the same time?
Yeah.
Yeah.
And depending on where you are, I think Anne has a better likelihood of getting combination nasal medications. We have a far less likelihood of doing that where I am, so we're often using two different nasal preparations.
Yeah. Yeah, but it is nice to get that synergy. 1 + 1 = 3, like you said. All right, this is our catch-up question. We're getting down to it. Name a question patients frequently ask about INAH use. So put yourself in the patient's perspective here. How do I use the nasal spray correctly? How quickly will it start working? Do I need to use it every day or only when I have symptoms? Is it safe for long-term use? Are there any side effects I should watch out for? What do you think? Come on, phlegm fighters. Let's go, nasal ninjas.
to say, you're not voting for both of us. Come on.
I root for everybody. All right. So I just want everybody to win. All right. So do I need to use every day or only when I have symptoms? Yeah, that's the most common one I get. And then I get quickly. Yep, good. And quickly. So this is. I'm definitely copacetic with these answers. I've experienced a lot of the same things. Any comments here, guys?
No, I agree.
Totally mirrors what I
All right.
was
Well,
guessing too.
it's not. Doesn't really matter so much
It's
what we
the
think.
audience said.
We
right?
were not. No, it's what our survey says. Quickly, yeah. Yeah, they're right there. They flipped the top two, but they're well ahead. And how do I use it? No, everybody assumes they know how to use the nasal spray. They just just whatever. I don't know where they're putting it, but it's but yes, it's always good. Just like so, gosh, y'all know this way better than I do. But just like asthma, bring in that inhaler. Show me how you're using it. That's part of what we do. And you can correct with asthma, isn't it like 35% of asthma either lack of control or exacerbation are due to misuse of the inhalers? So we can do a lot of good work. So what I do in terms of setting for setting expectations, I do talk about with corticosteroids and intranasal antihistamines, it's an easier conversation, frankly, with antihistamines because I talk about that rapid onset of action and it's going to be reliable, that you don't get habituation necessarily over time, that they can maintain efficacy over time. And watch for triggers. Of course, that's something that I try to do. When I look at the notes from allergy, they're much better at counseling in this area. There's no doubt about it. So patients, when they're on treatment and they continue to have symptoms, I might try to ask about it, but I'm also starting to edge. Maybe this person does need that referral. They need the test. They need an allergen test, and then they need to have a more in-depth conversation about avoidance. I know for a fact, because I actually rotated on allergy. There were 45-minute visits, and they were great. I really enjoyed it. Like you said, history was really important there. And then talk about side effects and ways to reduce them and setting realistic goals. There was already a question as well about how to actually use these agents. And I think that, so here's my take, and then you guys can just jump in. So I think when patients decide they're going to use their intranasal preparation, the first thing they do is like, okay, tilt my head way back, get ready, here it comes, and then just kind of like, take any kind of angle whatsoever. And they're always using the ipsilateral hand, right? Whereas actually you want to use the contralateral hand. That way you get an angle. You want the angle to be lateral away, into your nares, and that the opposite hand helps. Also, you don't want the head back, which will make more of that medicine go into the nasopharynx. You actually want to have your head tipped a little bit forward. And then you don't inhale deeply, because that's another thing people do without, if they're not unguided, they'll take that big breath in and force all the medicine backwards. Instead, it's just some light sniffs as you're doing the inhalation, and then take a drink of water afterwards. You can take have some orange juice or something that can help to modify the bitter taste. But I think those are some of the things that work, and a little bit of education will save your patients a lot of stress, and then they're more likely to continue, and you actually get a good trial drug. Your thoughts?
Yeah, I just say point towards the opposite ear. I have colleagues who actually teach the cross hand technique. I guess I'm just not a fighter, so I just say, no, angle it towards your ear. That's where the swollen parts are. That's where the medicine needs to go. And you don't have to snort. You'll just get the side effects of the bitter taste or whatever you're taking, whether it's intranasal antihistamine, intranasal steroid, or combo. Regardless, you'll feel more problems if you snort it down the back of your throat by accident. So.
Do you all carry like models of potential? I know there's different bottles, but they do. It's a little bit more similar than say metered dose inhalers and other types of inhalers. Or is that not something
we actually do not in our office?
All right, just curious.
I do not. No,
all right.
I just show them with myself.
All right, yeah, you can use a Q-tip, something like that. We usually have those. So the best device here is it's not quite as complicated, but I just know that's wrong. First of all, where is it pointed, right? Yeah, it's pointed to that medial side, not towards the ear, so it's a problem. Also, no hands. This looks like something my kids would do. Both of them, two of my three have rhinitis, and they would stick it up there and then like have it stuck in place, like, Dad, I've got a problem, and they think it's hilarious. And meanwhile, that's where epistaxis comes from, by the way. So no, don't do that. So we talked about the best ways to mitigate against some of those side effects and make the drug more effective overall. So now we're on to closing remarks. So reminder, get your questions in. I've got a few to go through with our faculty, but I'd be love to hear some more. So really, you have some great choices, and patients are going to make their choices. They're going to make those choices initially without any of your guidance whatsoever, and so, especially for a specialist. Very rarely will they have, be going right to specialists. So for our PCPs out there, it's our responsibility to really try to address their needs. Intranasal antihistamines offer a lot in terms of that rapid onset of action. Nothing is more rapid than that. You get the medicine in the right place. And they are well tolerated. If they're still having symptoms, then you can add, especially if they're more on the intermittent side, you can add an intranasal corticosteroid. If they're more persistent, you may start with either of the agents, but have a low threshold for using them both in patients who have a demonstrated trial that is of adequate duration over several weeks, and yet they're still having symptoms. Then put the two together. You'd be better off versus likely adding an oral antihistamine, in my opinion. Any other takeaways that you guys want to talk about before we close up and do our final tally?
Yeah, I just think that it's important to recognize that all of the therapies that are available for the treatment of allergic rhinitis as a pharmacotherapy, they're all fair game. Like, you don't have to do this one first before you fail that, then you go to the next one. I think patients deserve access to all of the options that are out there. You folks are so privileged in the United States that so many of these are actually available over the counter. I just think that the message for physicians treating allergic rhinitis is to make sure they know this one works fast, but this is the other one that you do when you have persistent symptoms. You can add in the oral antihistamine. Again, just to recognize that you have options, and certainly if you're doing a full gamut of pharmacotherapy, that's when you definitely want to make sure you're engaging with allergist partners who offer immunotherapy.
I think the key, I agree with everything that my colleagues have said. The medications for allergic rhinitis treat symptoms. They don't actually change the disease course or decrease sensitizations. And that's the big, big difference between immunotherapy and medications. And I like what Anne said. You don't have to wait to offer immunotherapy until a patient has failed every therapy. It's really different discussions for different individuals. What are their goals? Do they want something disease modifying? But the privilege of taking care of allergic rhinitis with medications is that we do have highly efficacious, well-tolerated medications to choose from.
All right. Well, thanks to you both. Now let's get to the main event, which is looking at our final tally. There he goes. Okay, wow, just popped right up. The Phlegm Fighters just won and took them down. Not really even that close. I can't do the math on that score. Yep. Well done. Well done, fighters. All right. Good enthusiastic clapping there. All right, let's get some questions. Is there a role for intranasal saline to help control symptoms? Where does that fit in?
That's a great question.
Yeah, I mean, it's definitely an underutilized, under-recommended option, particularly for patients who have more chronic sinusitis as opposed to allergic rhinitis. I often have to remind myself to recommend it because it does work very well. I do, when the question comes up and I remember to talk about it, I do remind patients you can use saline 6 times a day if you can find the time. Safe and efficacious, especially good for flushing. And you don't have to use the fancy machines. Like, do you have a lot of the crazy machines in
you totally
US?
don't have to.
It
does a couple of things. It gets rid of mucus, right? It's clearance.
Yeah.
But it also improves the absorptive surface of your nasal mucosa for the medications.
Yeah.
So it's actually got a twofold benefit. If patients are willing to use it, I absolutely encourage individuals to do so.
Someone's writing that in the majority of patients with nasal polyps in their practice don't seem to have a lot of allergens on testing. Has that been your experience as well?
Yeah, I would agree with that. It's probably only about 30% of my nasal polyps patients who also have allergic rhinitis, or if they do, it's a It's a minor problem compared to the overarching polyps. Those patients definitely deserve to be referred either to an allergist or an otolaryngologist for the advanced therapies we have now for nasal polyps.
There's overlap between allergic rhinitis and chronic sinusitis with nasal polyposis. I encourage everyone who takes care of individuals with chronic rhinitis, worried about allergic rhinitis, to ask people about their sense of smell. Hyposmia or anosmia is really one of the more common symptoms with nasal polyps and sinusitis, but not so much allergic rhinitis. So it's a nice way to differentiate. And so often, patients have lived like this for so long, they don't volunteer that information. You have to actually ask them. I mean, they'll be like, oh, why do you ask about my sense of smell? I haven't smelled anything in 15 years. And that's a very high pretest probability for sinusitis nasal.
It's a very sensitive screening test, yeah.
I lost the question. Oh yeah, this is the eternal debate about blood-based testing for allergens versus skin testing.
So I'm a little biased. In my healthcare system, blood-based testing is not covered. I use it in my research practice because I have to. But no, skin prick testing is still by far the gold standard in my personal opinion for the diagnostic tests for sensitization. We actually address this though in our practice parameters about selecting patients for immunotherapy. If that's your goal of doing the testing, then when you couldn't see patients for skin testing like we had in the COVID-19 pandemic, you do have sort of testing equivalents, but all of the studies have been done for if you were trying to figure out if this person is a good candidate for immunotherapy, are they equivalent? The answer is yes. But for routine day-to-day practice, what are you allergic to? Skin prick testing is by far more accurate. Would you agree?
I completely agree. We really prefer for aeroallergens to do skin prick testing, which is quite non-invasive. It can be done in 15 minutes or so. We only kind of reserve specific IG testing for aeroallergens in settings where skin testing can't be done. Someone can't stop an antihistamine for some reason, or a medication that has antihistaminic effects. But really, the preference is skin testing for aeroallergens.
And from a cost-effective perspective, skin prick testing is so much less expensive than the specific IgE testing, individually or via panels.
Great answers. Thank you. What about using intranasal antihistamines in someone with known nasal polyps? Could that be an issue in terms of absorption? I'm not really aware of that, but I guess technically yes, but I'm just not sure if there's any. I didn't see any research that really pushed me to have a strong opinion.
So I don't think it's a problem from an absorption perspective other than my experience, and so that's why I'm going to defer to my learned colleague to my right. I've only ever used the combination product, so I have the benefit of pairing it with a nasal steroid. What's your experience been with solo intranasal antihistamines and nasal polyps patients?
Shazad, when she said learned colleague to my right, I assumed she meant you.
Yeah, I'm still looking to my right too, but no one else.
Speaker,
no one else is over
there.
there.
Like a ghost over there.
Nobody else is you.
I would say I don't think there's a problem, but if you have an individual with nasal polyps, nasal antihistamines are not going to get you.
Yeah, I mean, using steroids.
It's not going to be efficacious. It's for allergic rhinitis.
That was my feeling, is you need steroids.
So you really want to drive at the polyps and the sinusitis. And I like the previous comment that came up. Individuals with chronic rhinosinusitis with nasal polyposis tend not to have allergic rhinitis, or much less common.
Right.
So really, you're treating a totally different disease state. And in that space, you shouldn't probably be using nasal antihistamines if you're trying to achieve maximal efficacy.
Correct.
I thought I addressed this. Does tolerance develop to intranasal antihistamines over time?
Not in my experience, no. It's very different from the intranasal decongestants, where it's a huge problem, which you already were kindly alluding to.
Right. And guess what? That's the end of the questions. We're happy to stick around for a few minutes. And thanks very much first of all, to everybody online. Thanks to everybody in the room. We know everybody's very busy, so hopefully you found this session helpful, very pragmatic for your practice. And take care. Enjoy the rest of your conference.